Witamy
Good
Was.
evening, ladies and gentlemen. I'd like to welcome you to yet another of our meetings, our webinars, that is devoted to ways of supporting traumatized people, how to find your place, how to get along in this situation. Even to us in Poland, we are absolutely shocked. We are completely ruined. We are completely terrified by what has been happening, let alone those that have stayed in Ukraine. Now, at the same time, we have a specific job, a job to be done to support those that are traumatized. And obviously, we ask ourselves how to do that by taking into account the very suffering of those with whom we work, all the more that we are ourselves suffering. So hello, everybody, once again. Good evening. We are happy that you are with us, that you've joined us, willing to gain knowledge and experience in preparation for those huge challenges. And we'd also like to welcome our great friend, Ryan Kennedy. We're so happy to have you. We're so happy that you've responded so quickly, well, instantaneously, virtually, that you are ready to help us in any form whatsoever. We appreciate it very much, and we also know that our Ukrainian peers appreciated that as well. We have heard a lot of signals, and it means that we can indeed do something with this terror, with our helplessness, or even sometimes hopelessness. Now, a very important subject: how to actually adapt the offering of our care to what the client has in store for us. The floor is yours, Ryan.
Okay, let's get our slides up here, everybody. So we are here today to talk about something called trauma-informed care. And the subtitle I have for this is, how do we transform good intentions to effective skills and tools? Because sometimes our good intentions can get in the way of being effective. The main point or the main theme of trauma-informed care is starting with this idea that what happened to our clients is this perspective we want to be looking from and through, not looking at what's wrong. So I'm very happy to be here, and our slide, here they come, and I appreciate the invitation to share this information with everybody. Thank you for joining us. I really hope that these tools and ideas are useful to you. One key here that I want to point out as we go through this is trauma-informed care is about two nervous systems interacting, yours and the client's. So it's going to be really important that you take care of yourself as much as possible while you are in space and in the room and in conversations with people who are coming from situations and circumstances that have historical or current or both forms of trauma. If you've got questions, please feel free to use the chat box, or you can post them in the comments area and we will get to them as we go along. See here, I was thinking as we were moving through this that we might take about a 10-minute break. I'm not sure if that would be something useful to you, if you just want to use the whole 2 hours, so let me know. The reason that I think it's useful to take breaks is that, again, I'm trying to model for you and for, really all of us here, that if we don't include ourselves in the conversation about trauma-informed care, the tool that we are using, which is ourselves, is less and less effective and can really lead to burnout and less effective kinds of ways of interacting. So we'll see if we want to have a break, or even just a quick break, so we can kind of take a breath and take care of ourselves. Okay, so main things that I want to focus on, our objectives here, is to understand what are the principles, what is the philosophy of trauma-informed care. It's really a lens, a way of seeing, a way of proceeding with our clients. So we're going to talk quite a bit about that. We also want to look at what are some strategies that support what I call a safe enough environment, safe enough. So it's not really possible to create absolute safety, in other words, because as we can see, the variables in the world are unpredictable. So we want to support safe enough places for people to get started and to be able to start unpacking what they are carrying around. And part of that is minimizing the presence of potential triggers if those are known. Sometimes they're not known, and sometimes they show up and we are asked to work with them. And that's okay. We can't know everything. We can't predict everything. So setting the stage for processing triggers as they show up will become very important. And they can be our own triggers as well. The third thing is to recognize the difference between what we're going to call trauma sensitive environments, trauma informed care, which is really the focus of what we're talking about today, and the last thing, which is trauma specific treatment. All three of these things are important to know about and to have some access to. And it'll be beyond the scope of our 2-hour presentation to go too far down the channel of what trauma-specific treatments would look like. That's really specific, but we're going to focus more on the trauma-informed care part. One key feature of trauma-informed care is understanding what the triphasic, or the 3 phases, 5 steps or stages of trauma recovery are, and recognizing those so you can see them in your clients. You can help them navigate through them. It will not be a sequential process. Most likely people go up and down through this, but really being able to see those phases. What are the key aspects of each phase? And how do you change the kind of support that you are providing and interventions you're providing based on those phases or stages? Most of all, I think what trauma-informed care helps me with, and hopefully helps you with, is empathy, the state of having curiosity about and a non-judgmental engagement with someone else's emotional world. And one of the things that can happen with empathy, we'll talk about in the second part of our class, is we can get pulled too far in and lose our center and become ineffective. And we can also lean too far out and become disengaged. So finding a dialectical balance, or a state of being able to see the world through someone else's eyes without falling into their world or disengaging from it completely, is a skill to be cultivated, practiced, and come back to over and over again in our work with trauma. Staying curious about what happened to people instead of rushing to judge, which is kind of the more disconnected version, or label, or fix, which is more of the jumping in too far. Want to keep those all very sorted. So just a bit about me. I come from a long history, about 25 years or so, working in trauma environments, working with people who have experienced histories of early childhood abuse and neglect, sexual assault, domestic violence, those kind of things, as well as working as a clinical supervisor for a program here in Denver that focused on people seeking political asylum and refugees from other parts of the world, and trying to support kids, parents, families who were new arrivals in a country where they did not know the language, didn't have access to resources, housing, jobs, etc. So I'm very familiar with this topic and what you all are stepping into as you are welcoming a flood of immigrants who are seeking refuge and asylum. So let's just take a minute and resource. I've got a picture here of our mountains. The concept of resourcing is key to doing trauma work, and resources can be internal, they can be external, and hopefully they're a bit of both. So internal resource might be a memory, might be an image, it might be a belief. Just see if you can come up with something for you that's an internal resource right now that you can take a breath into and hold in your body, feel in your heart, image in your mind. And you might also think about your external resources too. People in your life, access to housing or food, any of those things. And let it be okay that you have them. Sometimes when we're doing trauma work, it's probably not uncommon and probably not unexpected that people can feel guilty about what they do have in the face of what others don't have. And that's empathy at work. And it's important to name that and recognize that. And at the same time, it's also important to let yourself be resourced so that you can be supportive and present for the trauma, the adversity, and the horrors sometimes that we face when we are sharing other people's stories. All right, let's see here. What is trauma-informed care? So here is a quick definition. Trauma-informed care is an organizational structure. And I want to highlight that. I'm just going to take this one piece at a time. So ideally, obviously we're talking about ideals here, but ideally we want to be in work environments, practice environments, hospitals, treatment centers, private practice, where the structure of the organization supports you in providing trauma-informed care. What we don't want to see is that the clinicians are being asked to provide trauma-informed care in work environments that aren't really supporting that. And that would be a process where managers or leaders need to really be asking, how do we support clinicians to provide this kind of framework? So it's a treatment framework that involves understanding, recognizing, and responding, hopefully effectively, to the effects of all types of trauma. And the emphasis here is on physical, psychological, and emotional safety for both the clients or consumers who are receiving the services, as well as us, the providers, the supervisors, the administrators, the staff who maybe aren't clinical, but more providing supportive services. One key here that I want to emphasize, and hopefully this translates well, is the difference between crisis and trauma. And the conversation for you to be thinking about and for all of us to be asking is, are we dealing with a crisis or are we dealing with trauma? And this becomes a real question. What are you being asked to do? Now, a crisis probably is more what we're facing right now. A crisis is something that you're in the middle of it. It's when life as you knew it becomes unhinged or ungrounded, and the old ways of processing or coping just don't work because for whatever reason, they're not available. The situation's so grave or extreme that those strategies are rendered ineffective or incompatible with the situation. So be asking yourself as we're sitting here, am I dealing with a crisis? Am I dealing with a trauma? What's the difference between them? And how is my response going to be shifting here? So we're not really doing a crisis intervention class right now. We're focusing more on trauma-informed care, but you need to know the difference. So briefly, crisis is a situation that significantly threatens your coping, equilibrium, ability to cope. It's temporary, typically, and resolves, and the individual returns to a pre-crisis level of functioning. And if it doesn't get resolved, it can escalate and turn into trauma. So my guess is that some people may be in a state of crisis right now. Some people might have exceeded that already and be headed into a more traumatic response. And it's hard to know that unless you're really assessing people individually. We'll talk more about that later, and we'll look at the 3 parts of a trauma. Crisis is an overwhelming emotional reaction to an event, not necessarily to the threatening situation or event itself. So the emotions, the internal resources are not functioning as well. Temporary, a key word here, temporary. And you can see on the slide here that we have a baseline or a starting point, something happens and the nervous system goes into a fight or flight response, and it's able to come back down to the pre-crisis level of functioning. So a key with crisis is really the main goal of crisis intervention is to help people get back to what they were doing before, their pre-crisis level of functioning. Very different goal than trauma treatment. By contrast, we've got trauma here, and this is anything that overwhelms the ability to cope. So it's so extreme or pervasive or both that we just can't go back. The person is changed from the inside out, probably forever. It's going to be something that is going to be part of their narrative. And what we see here is important here. We've got 2 lines, a bottom line and a top line. And we might consider the bottom line the cold part of trauma. Cold meaning that the symptoms are going to be on the shutdown side of things, the parasympathetic nervous system kicking in and shutting things down. That's the part of the nervous system that's sometimes called rest and digest. And symptoms will look more like depression, slow, lethargic, not really feeling alive, a sense of deadness, exhaustion, chronic fatigue, not really oriented, feeling like one might be floating, disconnected from others, like a robot, wooden, sometimes people will say. And the body is reflecting those same things, lower blood pressure, heart rate, people might even feel cold. And then we've got the upside here. So this window from the lower extreme to the higher extreme. And this is the hot side of trauma. Trauma has 2 sides, a hot and cold side. Here we're seeing the sympathetic nervous system kicking in and all the things that go with that, anxiety, panic, a lot of maybe shaking or rapid movements, hyperactivity. Their startle response is engaged, they're jumpy, they can't relax, can't sleep. They're looking for problems. That's what hypervigilance means. Their body digestive system is probably not working very well. And that's because in this sympathetic arousal, the blood leaves the center part of the body and goes to the peripheral part of the body so that one can fight or flee. And that means that we're not getting the body's not really taking care of the digestive processes. So people can feel a sense of anxiety, distress, have digestive issues. They're flooded emotionally, there's chronic pain and hard to sleep, and they might be directing some of that out as rage. And we see here with this traumatic response that there's this oscillating kind of to the extreme and then beyond the extreme. And once people are outside of this window, we call this the window of tolerance. What can you tolerate? What are your coping skills? And once that's exceeded, we are headed into the trauma zone. All right. So we've got a slide here that shows mild or minimal kind of trauma reaction, and we have a more extensive trauma reaction. This might be something we would consider stress or crisis. We've got our 2 nervous systems here, our cold response, parasympathetic blue, our hot response, sympathetic red. And we're seeing how when the stressor happens, they both kick in to try to re-regulate the body. That's homeostasis. That is equilibrium. That's normal. It's healthy. We want that. And then we get a little bit of rebound and we come back to normal regulation. Here in this traumatic response, we're seeing a very different profile. The stressor happens and both systems kick in. And sometimes we talk about this as, if you can imagine driving your car, pressing on the gas pedal and the brake simultaneously. You're going to exert a lot of effort. It's going to take a lot of energy, and you're going to go pretty much nowhere and burn out the system pretty fast. So it's a high energy state, so this traumatic response without a lot of movement. So when we're thinking about these things, crisis, trauma, the distinction between the two, and discerning what exactly is trauma, one thing in trauma-informed care that is key and important here is what we in English call the 3 E's. And it's asking what event happened, but that's not enough. The event is the circumstance. And the key here is that it may cause trauma, but we don't want to be in the business of saying an event itself is the cause of a trauma. It's part of the cause. The other part is going to be the experience that somebody has, the subjective experience. And this has a lot to do with their resources. Remember those internal resources, their beliefs, their meaning, their resiliency, those kind of things. So the individual's experience of the event determines whether it actually becomes traumatic. So in the trauma-informed view of things, we wouldn't say that a car accident caused a trauma, or a particular kind of childhood caused a trauma, or even exposure to an event. But we want to do is ask, what was the event? What happened? What was their experience of it? What was it like to be there, to witness that? And then we're looking at the effects of the trauma. So some kind of thing happened. What are the effects that we're seeing on the body, which is where it's really going to initially reside? Trauma lives in the body. It's like an unprocessed experience, and it's going to show up first in the body and stay in the body until it gets resolved. It's going to show up in relationships, the social world. What kind of things are happening there? Oftentimes people go to the extremes. They'll either over isolate, or they'll over connect, or go back and forth. Mental, emotional, and even spiritual consequences. And by spiritual, we might say existential meaning. What meaning are people putting on this, and how does it affect their schemas, their worldview, how they look at themselves, how they look at the world and other people, how they look at the future? So those are the 3 E's. Trauma, so to summarize, it's not an event, it's not a singular event, it's not something that happens, that's part of it, but it's the experience of it that lives in our body. And when it's registered in our body, our bodies in their wisdom activate their own process of trying to get us back to a state of balance and a state of equilibrium. And the difficult part about this is that it's not possible to get back to equilibrium if there is not adequate internal or external resources. What does that mean to us as trauma? So we're talking about this idea about resources and accessing resources. And the question for you as the provider to be engaging with your client is what are those resources? Because without them, it's going to be hard to do trauma work. So let me just say something about that right now that's really, obviously going to be a big theme in working with refugees coming from Ukraine. And that is that it's hard, maybe impossible, to really do effective trauma resolution. The key here is trauma resolution if people are currently in a dangerous situation. So, you could think about people who are still in Ukraine, who are living in daily fear of an attack or whatnot. It's going to be almost impossible to do trauma work on that level because it's a crisis. It's not resolved. It's ongoing. People who are out of that maybe can do more trauma work, but if they've got, for example, loved ones, or they've got roots that are still under threat, it's going to be hard to let down the guard. In fact, probably not very useful to let down one's guard if there's the fear and the possibility of future, violence happening. So sometimes I think that's part of doing trauma work. I think about, for example, even working with kids living in abusive, maybe families, or where there's domestic violence or alcoholism, those kind of things. how do we give people the tools to manage that when the danger persists or when the difficulty isn't able to be resolved? Different kind of work than when the difficulty is over, the trauma isn't happening any longer. All right. So possible sources of the trauma here, when we're looking at this, obviously we're looking at loss, and we've got war, we've got terrorism. That's the big one that's happening with the refugee crisis right now in Poland. So that's going to be about loss. It's going to be about grief. It's going to be about what could have been or should have been that didn't happen, what did happen that shouldn't have happened. Lots of confusion and grief and loss around that. Death will be on the list. Abandonment, maybe feeling abandoned by the world or by the government, or who knows, but being on the lookout for those. Separation obviously is going to be a big one. The effects here of abuse. Sometimes I'm not getting this from the news, but sometimes refugees can feel unwelcome. They can feel confused by countries that maybe aren't as accepting or pushing them to integrate and leave behind their customs. Hopefully that's not happening, but might happen. Might also show up in schools, kids who are starting school, new to school, and maybe feeling some of the effects of bullying, perhaps. Witnessing violence sometimes doesn't get as much airtime as it needs to. And this is us as providers. When we are on the ground floor, when we're first providers, we are hearing direct stories. This actually starts to meet the criteria for post-traumatic stress disorder. In English, we call it post-traumatic stress disorder. So we want to be taking care of ourselves as we're bearing witness to the egregious experiences that clients are going through. Chronic stressors. This might even be happening with people who have a lived history or a family history of previous wars in Europe, where the collective memory remembers previous things like invasions and occupations and partitioning of countries, et cetera, et cetera. Very important to be looking at how that chronic stress in the population that is coming, the refugee population, as well as in the folks, who are there providing the service. There's a layer happening as well at that chronic stress level. So when we're looking at types of trauma, the trauma-informed lens likes to distinguish a bit some different types of trauma, because our ability to reflect and provide services can be informed by this, although these aren't always very distinct. They can overlap quite a bit. But to be thinking about, is it acute? Is it something where the symptoms are showing up in the first day, first few days, first 3 to 4 weeks, usually about a month when we're looking at acute trauma, versus chronic trauma. Chronic trauma is happening it's been going on, the symptoms are more than 6 months. You're seeing chronic trauma. It's going to be easier, if you will, or maybe more targeted if we know what the trauma was and it's acute, and we can really jump in there and focus on it before it becomes chronic. So that's what we're doing now. We're saying we predict that there's going to be trauma. We predict some people are going to be experiencing severe symptoms. Let's get in there. Let's start working with it right away so that we can be more effective in our approach. A simple trauma doesn't mean that it's not complicated. It just means it's one thing, and we know what it is. It's identifiable, like a car accident or a bank robbery, witnessing a crime, witnessing something difficult. We can target that thing. We can work with it. A complex trauma is when a simple trauma doesn't get resolved, and the symptoms of that simple trauma start to affect other experiences, other relationships, and that affecting process starts to create new traumas. For example, somebody might have been bullied in school and they shut down. And because they're shutting down, other people now maybe treat them in a way that would lead to more bullying. And so they start to have complex trauma. They get excluded, neglected. And that's something we don't want to see happen. We're trying to intervene early if possible so that acute trauma doesn't become chronic and we can start to discern how to approach the resolution of that. Shock-based trauma is usually witnessing something or going through something so violent and so extreme that the nervous system just shuts down. And my guess is that you're going to be hearing stories of that. And that is a clue that what you're hearing and what you are witnessing is going to need a lot of resourcing right away. That's going to be a starting point, because we can't really do a whole lot of trauma work at all if the nervous system's offline. And that's going to be more focused on our trauma-specific treatments versus trauma-informed care. So we need some treatment strategies to be looking at how to start with shock-based trauma. Developmental trauma or crisis is looking at babies and toddlers, children, adolescents growing up. How does a situational trauma, an acute trauma, or a simple trauma that doesn't get resolved, it turns chronic, maybe becomes complex, how does that get in the way of what we'd consider typical developmental milestones? And that's different from shock-based trauma, but also connected, because obviously if we don't deal with what's going on, it can really lead to later consequences. Fear-based trauma is connected to all of this. It's living in a state of chronic fear about something happening next that we don't have control over. Betrayal trauma, when a loved one who is supposed to be a source of comfort becomes the source of fear, and it can really trap. Usually it's somebody who feels trapped or is trapped, a child, a domestic partner, in a scenario where they can't escape. And this can lead to things like Stockholm syndrome, and we're not going to talk a whole lot about that, but it's a syndrome where we can see people protecting their offender and stepping up to maybe even offer support for an offender for offending behavior. And we can see this betrayal trauma can also be at a collective level too, where sometimes we can, in English, we call it gaslighting, where somebody in power who's being traumatizing flips the truth around. A lot of times people who are victims of trauma are dealing with a psychological or emotional form of abuse where the trauma gets turned around and they become the cause of their own trauma because of the way that gaslighting works. And that's very difficult to experience when you are providing treatment, because you recognize that they didn't deserve it or ask for it, or they weren't the cause of it, but in their mind, they're kind of taking some of the responsibility for it. And it can be very confusing for providers. So we want to be on the lookout for the effects of betrayal trauma. It can really affect how people's attachment systems work. They become very confused sometimes and might even seem to be seeking out people who are dangerous. And again, we want to be careful about judging people when they do that, because it looks like they're choosing to do it, but it's a trauma symptom. So again, we're going back to the definition of trauma-informed care, and that is, what happened to you that makes this behavior make sense versus what's wrong with you that you would be doing something like you're doing. Social trauma is exactly what we're facing right now. It's so large scale, so pervasive, that it is not just singular, not just in a family, but it's really affecting all levels of society. Ambient trauma, when the neighborhood is dangerous, there's no turning it off, home isn't safe, stray bullets, those kind of things. Intergenerational trauma might be happening with people. And you can see, maybe hear stories of that where there may be somebody from a country like Ukraine is there seeking asylum themselves from another part of the world. And so they've got generational trauma, intergenerational trauma, and now are experiencing another wave of that. Vicarious secondary trauma is the providers, us being exposed. How, when, where, frequency, how often, and who did it are key questions when we're looking at the type of trauma and what our trauma-informed approach will be. So 3 things to remember when we're thinking about trauma-informed care. What happened to you? And a follow-up question to what happened to you is that makes this current set of behaviors I'm seeing, symptoms that you're experiencing, and relational patterns that you're engaging in, what makes that make sense? Because from a trauma-informed lens, whatever you're seeing makes sense if we're curious and we look at how it's all connected. What are the symptoms we're seeing? And we're going to be seeing symptoms as adaptations to traumatic stress and maybe even chronic traumatic stress. And then healing is possible. And I think this is one of the most important things in doing trauma-informed care, and that is that you believe in your core that healing is possible. It is so important that your sense of hope and belief in the process is intact, because they're going to be borrowing our hope in a lot of ways. They're going to be borrowing from our belief that this is something they can move through and get through, especially in the beginning of treatment. So it's so important for us to not be false with our hope and not say things that are obviously cheerleading comments or kind of encouragers that don't reflect the gravity and the severity of the situation. We need to be honest, but we also need to say, I believe that you can work through this, and you'll probably be different because of it, but different's not bad. Different's something we can work with. And that's going to be in a relationship. So we are creating healing relationships with our clients. That's the start. That's the first step in trauma work, is creating a healing relationship. So important here is the effects of trauma on a person can often be conceptualized as being a normal reaction to an otherwise abnormal experience or situation. We want to convey that what they're going through in their body, in their mind, in their emotions, in their relationships, it makes sense. And other people are likely experiencing similar things. All right, let's take a look now at trauma-informed care development and a bit about the brain, some things that you want to just keep in the back of your mind. These aren't necessarily things that you're going to be saying to clients, although sometimes clients can benefit from hearing them, but usually they're more things you want to just be on the lookout for. So the experience of trauma can be short-term, it can be long-term, and probably will be a little bit of both. A lot of times the impacts aren't immediately recognized or recognizable. So months later, years later, we're seeing the impacts of trauma. It changes the brain. It changes how memory is stored. It changes how people proceed with their lives. It affects coping responses, interrupts the ability to engage in meaningful relationships, and it can slow down or impede mastery of important developmental tasks throughout the lifespan. The impacts of physiological responses, it can diminish our psychological well-being and harm social relationships and shape or alter our core beliefs about what life means and what events are important to us. Signs of trauma are behavioral, emotional, and psychological. Some of the things we see in behavioral: blowing up when people are corrected, fighting when criticized, resisting transitions or change, being very protective of personal space, reckless or self-destructive behavior, frequently seeking attention and maybe regressing or reverting to younger behaviors, very common behavioral expressions of trauma. In the emotions, we're seeing things like sleeping problems, night terrors, nightmares. Sometimes people are afraid to turn off the lights. They're wanting to keep the lights on. Sometimes they don't even want to be in bed. Remember, and I think this is sometimes a place where well-meaning therapists can really miss it, really go wrong. And that is that when we fall asleep, we lose our ability to make choices. We lose our ability to respond. So sleep itself can sometimes become a trigger for people because it's a time when we lose our autonomy and we become more vulnerable. And obviously, if people don't sleep, their mental health becomes more and more jeopardized. So people need to sleep in order to function. But again, sleep can be a real fear for folks if they're living in states of chronic trauma. So working with people around getting better sleep, triggers around sleep, looking at beliefs around sleep, what are the safety features in their environment that might support that, can be a really necessary place to even get started. And sometimes we don't even ask the question about sleep because we're focused on other symptoms. So be on the lookout for that. And you might need to do some creative exploration and problem solving around sleep. Sensitive to noise or touch, boundaries. Again, well-meaning people oftentimes want to lean in and they want to be helpful, sometimes even touching folks who are not wanting that. They're super hypersensitive to these things. And some people want it. So be careful. Maybe even ask what would be helpful before approaching somebody. Fear of being separated, difficulty trusting others, quite common, feeling sad, angry, afraid. And unexplained medical problems. This gets into something that we look at called idioms or languages of distress. And people oftentimes, especially from different cultures than what we're used to, might have ways of expressing anxiety, fear from a cultural perspective that looks different from what you might be used to. And sometimes that's related to, well, frequently it shows up as somatic symptoms. And you can be probably guaranteed that you're going to see some of that, especially those digestive symptoms. But sometimes you'll see neurological symptoms show up where there's tingling or there's things going on with the senses that don't really seem to be related to anything. And those would be ways that the body is being affected by trauma. Difficulty imagining the future is a psychological symptom. And again, the tendency is to want to be hopeful. Someone doesn't see there's a bright future and we want to jump in with, well, come on, yes, there is, there's a lot to live for, a lot to look forward to. Well, that's jumping in to try to fix things rather than really being with somebody where those symptoms are. So it's normal for people to have a sense of foreshortened future. They're not sure about the future, and to really ask yourself, how is that adaptive? How would that be useful? And there's a lot of conjecture about how that might be adaptive. But one of the main ways it's adaptive is people just need to get through today. Today is the survival strategy. We need to focus on getting through today, and tomorrow we're not worried about. So as we work through the trauma, as we get more resourced, then there's more bandwidth, there's more psychological capacity to start looking at the future and even imagining the future. It's overwhelming psychologically to have the future taken away over and over again. So part of what the brain's adaptive feature is just stop thinking about the future. Some other trauma responses, I already went through most of those. What I do want to mention here is the brain builds from basically the bottom up. So as kids are are growing. That's essentially how the brain functions are stacked from the bottom up. And the bottom regions of our brain control things like our breathing and our heart rate, our blood pressure. And the top regions control things more like logic, emotional regulation, those kind of things. And the brain, the human brain at least, is born underdeveloped as a feature of our species. We have these big brains, and they have to be developed over time. So our kids are going to be especially vulnerable to trauma because of these underdeveloped brains. It takes about 22 to 25 years for the human brain to really reach a state of maturity. And during that time, they need healing relationships and a lot of support, encouragement in order to get to that place where they're fully functioning as adults. So when traumatized parents are trying to raise kids and they don't have themselves on board, they're in a trauma state, it can really affect not only them, but their kids as well. So family work to mitigate the effects of trauma has a generational effect, is what we're wanting to impart here. We've got a picture here of a deer in headlights. The headlights are coming at the deer is frozen. This is something called a bottom-up reaction to fear. And I want to highlight the intensity of this. So the brain's fire alarm is located in a structure called the amygdala. It's part of the emotional brain. And this amygdala activates under threat. And it doesn't matter if the threat's real or perceived. And a lot of times perceived threat is what happens when a person is afraid of a real threat or exposed to a real threat. The body doesn't really distinguish whether it's perceived or real. But if the threat's there, then what happens is the front part of the brain, the thinking part of the brain, starts to shut down and focus on survival. And the ability to perceive new data goes down. So we're just able to take in what we've known, what we've learned. And this is one of the reasons why sometimes when we're working with people who are in states of crisis and in states of trauma at the high end, if we're doing things that are kind of cognitively focused, cognitive behavioral therapy, logic-based rebuttals, looking at here's the irrational thought, here's the rational thought. Sometimes these things just don't really work, especially in early treatment, because the thinking part of the brain is kind of offline. So we want to maybe have some other strategies to help people get supported and resourced so they can get their thinking brain back online. There is a part of the frontal cortex on the left side called Broca's area. And this is the part that helps us speak. It's responsible for organizing speech. So if that frontal cortex starts to go offline because of trauma, it's hard for people to talk. And so people can get triggered, they can get into an emotional, difficult place. And you're asking, what's going on? How are you feeling? What are you noticing inside? And those are all questions that would really require someone to be able to reflect on their experience, put words to it, report back to you, and they may just draw a blank. And I want to highlight that's common and normal if that happens. And it's a clue that you're probably starting a little bit higher up in the treatment process. And again, we want to go back to the beginning and do some of those, looking at the safety, the relative safety, as we mentioned, because you can't guarantee absolute safety. Looking at the healing relationship that you have established in the beginning and continually to address with your client. And then you're building through resourcing to the place where now with that ability to talk and report back is back online. All right. So reactions to trauma are oftentimes presented as problems, especially from people who are jumping in to help. A lot of times, socially speaking, when there's a an event that goes on that is devastating, the initial reaction that people have is, let's do something, let's help. When people jump in to help. And as it continues, as the problem persists, then some of these other things start to show up. And one of the things that can show up is, I'm here to help you, but you're not wanting my help. You're being combative. You're being non-compliant. We're offering these services to you, but you're coming late. You're leaving early. You're not being nice. We're trying to be nice to you. So we get the client who's non-compliant, maybe even combative, and we're trying to help them. It's kind of a fighting response. And it's, again, may not be happening to you, but it might happen to you. And you don't want to be judging that, saying, well, these people, we're trying to help them and they're not helping, they're not wanting our help. So we can reframe that as struggling to regain or hold on to personal power, and not jump into being non-compliant or combative. We might see people who are treatment resistive or uncooperative. They're not responding to our interventions. And instead of seeing that as flight, they're trying to get away, we can see it as disengaging and withdrawing to protect themselves. Here's another relationship where somebody might abandon them, or they get connected to somebody and only to find out that the person is not going to be there for them like other people were. The freeze response. This is oftentimes related to betrayal trauma. Don't know whether to go forward or backward, don't know whether to open up or shut down, so just kind of stuck in the headlights. Passive, they're not doing anything. They're unmotivated for change. Might be some of the pejorative or negative ways we have of conceptualizing that. So we want to avoid that and be looking at giving into those in power, because resisting is worse. And that's a adaptive response when you can't escape, when you just kind of say, whatever you want, I don't care anymore. No, again, making sense of these reactions instead of judging people or framing them as pathological. Some of the factors that increase the impact of trauma are, is it happening early occurrence? So obviously the younger someone is in their brain development, the more it might have an impact, especially if it's chronic or turns into complex trauma. Remember that brain is still developing up to about 25. So we're not just looking at babies and the first 5 years. We're really looking at the first third or fourth of life. Blaming or shaming, where they blamed for the trauma or shamed because of their experiences of trauma. Some of the messaging out there might be to buck up, to not say anything. Other people have it worse. And so people can feel ashamed of their own emotional intensity, their own fear, because they're needing to put a brave face on. So they're angry with themselves. Sometimes gender has something to do with that, where someone's being told that they need to stay brave and maybe they're afraid, they can't talk about the fear. So that would be something to think about. The perpetrator is a trusted caregiver, and obviously that leads to some more significant problems because of the going toward and going away phenomenon we mentioned earlier, and being silenced or not believed. So again, we want to listen to victims of trauma. We want to hear their stories. In English, we say, what is shareable is bearable. What is shareable is bearable. If they can tell the story of the trauma and stay in relationship, then it's going to be something that they can start to integrate. And if they can't tell the story in a way that's relational, then it's unmetabolized and it continues to have its effect. Now, I'm not saying that people need to tell their story or need to tell it in detail. There's different viewpoints about that. What I am saying is that they need to be able to tell parts of the story or elements of the story. It doesn't have to be the whole thing, but what did happen. But they want to be able to do that in relationship to you. And by in relationship, I mean that they stay in that window of tolerance that we looked at earlier, right? So we had that high end, we had that low end, the hot symptoms of trauma, the cold symptoms of trauma. And as they're telling the story, can they get to that top but not go over? Or if they do go over, we can help them come back. Or if they get to the cold spot. So we want them to be telling the story in this window, right? Because the window is where the relationships happens. And if they're telling the story and they're too hot or too cold, they aren't going to be able to stay in relationship. And then telling the story becomes actually a re-traumatization rather than a resolution of trauma. So very, very important as we're working with clients of trauma to be tracking where they are, the parts of the story that they're telling, that they have the skills and the resources to tell the story, and that they do it in that window of tolerance. And that's a lot to be tracking and managing as a clinician. And that's where your trauma-specific treatments are going to really be useful to you. Things like EMDR, things like trauma treatments, things like DBT skills that are going to help teach some of those elements that maybe somebody didn't get or doesn't have because of the trauma. We like to mention something called the ACE study that happened in the United States about 25 years ago or so, and that stands for Adverse Childhood Experiences. So we're not talking about children here and trauma. We are talking about childhood experiences that then become big problems 20, 30, 40, 50 years later, we see in adults. So you might be working with people who are coming from Ukraine, who have gone through this experience, but then they themselves might have had historical issues of growing up in environments that were less than ideal. And so that can affect, your approach to somebody who's coming in for treatment. And some of the things that I just want to mention to this, with the adverse childhood experiences in the early age can lead to disrupted development. So we talked about those developmental traumas. And because of that, people might be turning to things to help regulate because their environment's not supporting them. So they're using food, or they're using drugs, or they're using behaviors to help feel good now. And those experiences of feeling good now can oftentimes cost them their long-term health because it gets in the way of social and emotional and cognitive skills. So they're impaired at that level. And they might even adopt risk behaviors like smoking, overeating, lack of protection, maybe if they're sexually active, and they end up with diseases, disability, and social problems 20, 30, 40 years later that leads to early death. And the ACE studies point to this again and again and again, that you might be working with adult clients who are showing some of these issues at the top of the pyramid here. And as we're exploring them, we can really find that they are traced back to early childhood traumas. And so what is the takeaway here? If you're working with kids, adolescents, young adults, we want to work on these adverse childhood experiences so this doesn't happen by giving them better coping skills. And if we've got adults who are trying to metabolize the situation that they're coming from as refugees, likely they're going to be turning to things like coping skills that help them feel better now, but then maybe are going to cost them a lot later. And what are some ways to help process those trauma experiences so they don't end up having to resort to quick fixes that cost a lot later? Some things that can help is obviously economic stability. These are going to be a resource. Getting people, if they can, involved in meaningful work or volunteering or something. Having understanding through education about what trauma is, what the effects are, that it's normal, social and community connection. They're integrated into places of worship, into schools, have a sense of belonging to their communities, that they're welcomed, that they have access to health and health care, little things, not just if there's major healthcare issues, but they have a relationship with a trusted provider, a dentist, an eye doctor. And what neighborhoods are they in? What's the built environment? Are there parks? Are there beautiful spaces? Or is it dangerous? Is it triggering? These are things to be thinking about in the long term. So I just mentioned the risk factors, these social determinants of mental health, conditions or attributes that when present increase or exacerbate the risk of trauma turning into, or crisis turning into trauma. The protective factors are going to help bring that down. Our goal here is resilience. We want people to be able to stretch or flex in response to the stress or trauma and not be destroyed by it. And that has a lot to do with their resources. Okay, so let's just take a quick little moment here. We're about, an hour or so into our presentation. And I think what we'll do is just take a deep breath. Again, I want to role model and experience with you resourcing. So, we've been talking for an hour. A lot of therapy sessions are about an hour long, and we need to recognize that the urgency of the moment shouldn't override the necessity of our own self-care. So it's okay just when you're working with trauma to say, this is affecting me. Let me take a sec. Let me take a deep breath. Let me feel my own body. Where am I holding? Where am I tense? Where am I tight? One of the important skills in trauma resolution that I've learned over the years is this idea of sequencing trauma through the body, so it doesn't lodge in the tissues and then create problems. So if you feel inclined, you could feel your toes on the floor. You could feel your feet on the floor. You could even press through your feet, through your heels, and feel a sense of groundedness, that you are here, that you are in your body, that you are present. You could roll your shoulders a little bit, take another deep breath. And I like to shake. So you could shake your hands like I'm doing right now, just flick them a little bit. You could shake your shoulders. You could stand up if you want. You could shake your head. And I think a lot of people feel silly when they do this, or they think, oh, I can't do this at work. Why would I do this? And what I say is give it a try. Shut the door, go to the bathroom, give yourself a chance to just try it out. And if it doesn't work for you, then don't do it. The reason that we encourage you to do a little bit of deep breathing and then shaking is in animal studies where we've seen prey animals get attacked by predators in the wild. What we see is that they consistently will shake after they survive. So, obviously if they get attacked and killed, then that's the end of it. But the body is going through a series of fight or flight responses to the rest digest responses. And if you live through a crisis, then the way to not have that stress turn into trauma is to sequence it through the body. And animals in the wild do that through shaking. You'll see it over and over again. And we are animals too, and our bodies tend to hold on to that trauma because we don't give ourselves, probably because of social conditioning, we don't give ourselves a chance to I lived through that. Let me readjust, let me recalibrate, give myself permission to say that did happen to me and I need to get myself back online because I went offline because the situation was overwhelming. Anyway, that's my little commercial for self-care. One of the many strategies out there. It's not the only one, but it's a good one. And I invite you to, explore it and see if it is useful to you. Okay, let's talk a bit about what trauma-informed care is. Remember, trauma-informed care changes our perspective from what's wrong with you to what happened to you. Staying curious is the key, not foreclosed and judgmental, or jumping into rescue. We don't want to be rescuing. I mentioned at the early part of our time together here that we've got three things. We've got trauma-sensitive environments, and we've got trauma-informed care, and we've got trauma-specific treatments. Let's make sure we distinguish these. So trauma-sensitive is an organizational view. And it's going to be looking at things like your website. how the phones are answered, what the receptionist says when people walk in, what are the policies that we have about people who are loud in the office, or people who come late, or people who maybe show up and they've been drinking. Lots of presentations here. The trauma sensitive environment trains the non-clinical staff to be on the lookout for that and to be asking, what else might be going on here, rather than being quick to judge or shut people down or turn them away. We want to be training other staff. And remember, this is not really about clinicians, although clinicians are part of this. So you could be asking yourself, okay, what are we doing in all of our levels of administration to invite people to come to our services and stay in services? People can get turned away, get turned off when they don't have trauma sensitive environments. I'll just give you a quick example here. A common one is people coming late. Remember, a lot of times when people have gone through traumatic experiences, it changes how their brain's functioning. Their cognitive processing systems might be somewhat offline. So people can oftentimes have an altered sense of time, and so they might be coming late. And if we aren't able to respond effectively, then they may not come back. Trauma-informed care, really what we're talking about, we have got 4 R's here. One is we are realizing the widespread impact of trauma and understanding the pathways for recovery. So we've got to see it in order to be effective. We need to recognize the signs and the symptoms of trauma in clients, the families they're a part of, our own staff, we ourselves, and anybody who's really part of this system. We've been talking a lot about signs and symptoms. In English, the signs are what you see as the provider. You would see them doing things, the behaviors they're engaging in. The symptoms are the subjective feelings or experiences that are internal. So both those objective markers and the subjective experiences coming together, you'd recognize those and be able to say, aha, I know what this is. I have a sense about what we're working with here. We realize, we recognize, and we respond in fully integrated knowledge about trauma. So we've got it built into not just our practices, but the policies and procedures as well. And we're trying not to re-traumatize people. The last thing we want is for people to come to us to help resolve trauma, and instead of resolution, we get re-traumatization. And that re-traumatization oftentimes is a result of not having the structures, the support, the safety in place. And that means that people aren't stable enough to do trauma work and they become re-traumatized. So I talk a lot about the 3 or the 4 S's, the safety, stability, structure, and support. They need to all be in place: safety, stability, structure, and support. Now, once we have an environment that's trauma sensitive and clinicians who are informed about what trauma is, how to see it and respond to it, then we actually need some services that are trauma specific. And this means that they have been shown to really help people metabolize what happened to them. And when we look at Judith Herman's model of the 3 phases of trauma and recovery, we're going to see that the trauma-specific treatment is really in that 3rd phase. And the first 2 phases are much more about the trauma-sensitive environment and the trauma-informed care, but they all 3 need to be together. And to belabor this point just a bit more, one of the sad realities when we get to looking at trauma-informed care is that we can get people who are taking classes or learning about trauma-specific treatments. I'll just randomly pick EMDR. This is the eye movement desensitization and reprocessing, where people are tracking with their eyes and they're reporting. So somebody might learn something like EMDR, which is a great trauma treatment, but they may not be applying it into a trauma-informed lens. So they're doing the treatment too soon, right? This is usually about stage 3 in our model. And they really need to be focusing more on stages 1 and 2 here. And they may not even have looked at things like their policies, their website, the phone system. So we are doing trauma work, quote unquote, trauma work too soon. And it doesn't have the infrastructure to support it. All of this is trauma work. We need all three. We need the trauma sensitive environment, the theoretical understanding about it, and then the actual skills and tools to approach it. So you could ask yourself now, where am I doing great? And where do I need to bolster our approach? Am I a decision maker? Can I, implement some of these things right away? Or do I need to involve my team or involve a manager or a supervisor? The trauma informed care approach really wants us to be looking at all three. Okay, remember I said a trauma-informed care has some theoretical understanding, and I want to give you a couple, there's a lot of things we could go into, but here's a couple that I think are really important. Number one is this phrase from Latin called corpus delicti, and it's actually a legal term. And what it means is we don't have, in this case, a murder. We don't have a crime if there's no evidence that the crime happened. Corpus delicti means the body of the crime has to be present. And the principle is that sometimes people's trauma symptoms is the evidence that a crime happened or a trauma occurred. And they unconsciously typically need you to know this happened to me, and they don't want it to be negated, that this terrible, awful thing happened. And a therapist, a well-meaning therapist, we hear their symptoms, we're listening to their story, they're telling us they want to feel better, and we get excited about treating their symptoms. And if you hear underneath that, what you're hearing is that we're trying to get rid of their symptoms. We're trying to get rid of their night terrors. We're trying to get rid of their hypervigilance, their racing thoughts, the beliefs that they don't deserve a future, etc. And corpus delicti says, if you're trying to get rid of that and they need those symptoms to validate that this happened to them, then you're kind of going to be working against your client. So what we want to do is we want to acknowledge and validate for people that this is true, that this is real, that it makes sense that they're feeling this, and maybe even not try to get rid of them, but to help them see those symptoms in a new way. And in the trauma-informed lens, that's usually as adaptive. Like, yes, we're not trying to get rid of your sleep terrors. We want to appreciate that your sleep terrors are trying to help you process something that was unimaginably horrific. It makes sense. Let's appreciate that your brain is working overtime to try to integrate this experience. And let's also appreciate that your body needs rest. And both of those things are true. So how do we work with your brain and your mind as an ally instead of fighting it as an enemy? This becomes a approach to therapy that's a little bit paradoxical, because you're holding two things that seem like they're not compatible together. So that's really a key feature here of working with trauma, is we're not trying to negate or invalidate people. We want to appreciate and recognize that it did happen. The other thing, or another thing that I think is useful, is this idea about shattered assumptions. And people have different takes on this, but the main takeaway here is that when people have lived in mostly first world kinds of countries where they've been just doing life, they get up, they go to work, things are pretty stable, pretty safe, pretty relatively okay, and they weren't living in ambient environments that were traumatic, they oftentimes will create these implicit assumptions about life, that the world is a pretty good place, people are good, and that things happen for a reason. Life has meaning, and things happen for a reason. Things are pretty predictable. You can count on, like the routines of your day and etc. That other people have bad things, but for the most part, I'm invulnerable to that, and I'm a worthy person. I'm worthy of good things. remember, these aren't facts, these are beliefs that people can have. But after going through a shocking, horrific experience, all of these get either threatened or destroyed. And a sense of existential overwhelm can really pervade somebody's psychological state. The world is a bad place. Nothing happens for a reason, or they have a catastrophic meaning. This happened because I deserved it. We can't count on anything anymore. Nobody's safe. So the brain kind of destroys all of these and says, I can't, I need to do the opposite. And that's a expected reaction, obviously, but it can also be in the way. So remember, the sympathetic nervous system is really about fight and flight, right? These two things, fight or flight. That's pretty black and white. There's no middle ground in fight or flight. And the brain needs to be more calibrated and integrated to get out of that. So that is going to be our next step here. So I teach people when I'm working with trauma, I will say, let's start to discern between your wise mind, that part of you that is able to notice things and describe things and see that it's a reaction that makes sense. We want to start to make friends with that, or create that, strengthen that wise mind. And we want to discern that from your other mind, which is going to sound a lot like trauma talking. So what's trauma talking sound like? And people may not even know. So I'll walk through this and say, well, trauma thinking, or the self-talk that you might be experiencing, is going to mix up the past and the present. It's going to oftentimes speed things up, maybe to a catastrophic end. They're going to be thinking, well, this little thing is going to lead to that, then to that. And pretty soon people can start to spin. Traumatic thinking discourages new thinking. It's hard to think of things in a fresh way because the template from the old thing is so pervasive and strong that it's hard to be replaced. It tends to make people attribute negative experiences to who they are rather than what happened to them. That goes back to the idea that good things happen to good people and bad things happen to bad people. And, so if you're thinking things are meaningful, that is oftentimes where people end up. Traumatized thinking tends to polarize. People get black and white. So it's hard to find the wisdom. It's either one or the other. This next one, trauma creates errors in knowing. And this idea about errors in knowing means that other people can see from the outside that there's something off here, but for the person experiencing it, they don't know what they know. And this oftentimes is the result of gaslighting or being in a place where there's emotional abuse. And that means that the offender is a known person who is both protective and frightening. It happens less when you have an invisible assailant or an anonymous person, somebody you don't know. Usually people are pretty clear that what happened is what happened. But you might be seeing, I know I'm hearing stories and reports of people who might have family, for example, in Russia, and the family doesn't, they can't hear that these other things are happening in Ukraine and ripping families apart because people don't know what they know. They don't have the right information. They can't believe that something like this would happen. And that might be part of the more political version of gaslighting, where you do know the person and they're both somebody you fear and also are supposed to be protecting you. And so that can lead to some of those things where people are really kind of showing examples of Stockholm syndrome on a cultural level. Traumatic thinking in the present tends to bring up unresolved trauma from the past. This is what I was highlighting earlier, where we might have some of those adverse childhood experiences that are affecting people today because of current traumas, and maybe even making future decisions that could affect their health much later. So we have a guy named Stephen Porges, who is presented this new model, well, newish, it's not that new anymore, but he's added this idea of a social nervous system to what previously was just the fight or flight system and the rest and digest system. So I just want to highlight this to you, and we'll talk about it very briefly, and then you can learn more about it if you want to Google polyvagal theory, and you could learn more. The idea here is that he's saying that the human brain, of course, is born early, and we're hardwired with a fight or flight system and a rest and digest system. And that fight or flight system, rest digest system is going to be online for people if they don't have social engagement. The social engagement system is the system that is about relationships. And typically people, as they're developing, will need someone else to regulate them. So a parent or an adult will help them regulate while they're learning how to self-regulate. So we have external regulation happening with internal regulation. And you might think of it even almost like 3 steps, where you've got your parasympathetic system is the lowest system. That's your rest and digest system. And your sympathetic system is your middle fight or flight system. And this social engagement system is really at the top. And somebody who's optimally acting in the world, they've got good enough support, they're feeling pretty safe, they grew up with pretty stable environments, they're probably operating here. This is the ability to see shades of gray and recognize things in a nuanced way, and to use visual cues and facial expressions and tone of voice to navigate and negotiate life. That's where we want people. And if they don't have that, because trauma knocks it offline, people tend to go backwards. So now they're kind of operating from fight or flight. And if that isn't working, they tend to go backwards, and they oftentimes just operate from this freeze response or even fake dead. They're lower here. So part of working with trauma is recognizing these phases and helping people tone their nervous system so they can move up and get to social engagement. Now, what does this say about you? Like, you've got a client who's doing this, and then there's you who's doing this too. So if this is your client and this is you want to be in your social engagement system, because you're going to be much more effective. If you're in fight or flight, or you're even so afraid that you're not able to support your client, then that's not going to be a very good situation. So we've got to have our own tools to stay up here as much as possible in our social engagement system, and be able to use dialogue, facial expression, tone of voice, body posture, gesture, our own breathing. Those are the things that are going to help do that. So that's called the polyvagal theory, and it's related to the vagus nerve, the 10th cranial nerve, and the idea that that nerve is the only nerve, cranial nerves, that leaves the brain, goes into the body, and has a lot to do with managing our physiological state based on our perception of safety. All right. That's a very brief focus there on that. I want to mention only briefly here, in looking at trauma and our trauma-informed care, remember that a lot of trauma is about grief, and grief about what happened and what is taken away because of what happened. Future plans, relationships. There's a lot of grief about what did happen and now is no longer available, homes and routines. And then, of course, there's the grief about what didn't happen that should have happened. Why didn't people respond? Why didn't anybody hear my calls for help? Why did this happen to me at all? You can get things like survivor's guilt, where people, maybe lived through something and a friend, a family member was more impacted or didn't survive it. And that can be another confusing form of grief. We can get very kind of obvious grief reactions, but we can get ambiguous grief reactions too. Now, remember that Kubler-Ross and these 5 stages here was really designed around people who were given a terminal diagnosis, and was more presented as a description of some common phases that people would experience, or stages people would experience when they were faced with a life or death situation. And it's not really designed to be proscriptive. So I'll say that again, it's descriptive. It's trying to give people a sense about what a progression might look like for people who have a terminal illness. So let's not get too excited about telling people, oh, this is how grief looks for everybody. These are the stages, and you should go through them in this order. That is not what I'm saying. What I want us to know is trauma and grief go together, and we need to be able to understand how to support people in this grief process and help them make sense of it. Grieve what happened that shouldn't have happened, or grieve what didn't happen that they needed but didn't have access to, and to be able to talk about that. And that taps into our own grief as well. So that's something for us to be continually looking at and talking about in supervision with our colleagues. The stages here, this can't be happening, it shouldn't be happening, why is this happening? Denial, anger, angry at the world, angry at other people, angry at oneself, bargaining, looking at what I could have done or should have done and why didn't I do. Sometimes blaming ourselves can get in the way. Depression and acceptance doesn't mean that they come to the place where they're accepting that this is good, but they're accepting that it did happen and is part of how they need to move forward. One of the things that can really get people stuck in therapy is not accepting. It's very hard to radically accept what happened, especially when we're stuck on why is this happening? It shouldn't have happened. This isn't fair. And of course, some of that's necessary and expected, and we want to appreciate the commonness of it. But we also want to recognize that it's going to be next to impossible to manage some of the symptoms that people might be having if they don't accept that what's going on is going on. And that means facing, things that are difficult to face. These are the stages that I was telling you about. Judith Herman, she wrote a book called Trauma and Recovery. You can see here at the bottom of the page, I gave you the reference for it. There's a lot of maps out there about trauma recovery, but this is a good one, and I want to just walk you through it. Remember, we have our trauma-sensitive environments. This is our organizational approach. We have our trauma-informed care. This is a lot about theory and understanding about, what the symptoms are, what the roadmap is, and then we need our trauma-specific treatment. So there's treatments that kind of go with these different stages, but we want to know what they are. So stage 1 and 2 is the first phase in our triphasic model. So we're going to call this phase 1. And then our remembering and mourning, stage 3 here, is really phase 2. And our last 2 stages here are going to be phase 3. So this is, we call it the triphasic model, and there's 5 stages to it. Again, we don't want to present this as linear and that everybody goes through it in some kind of a sequential fashion, but this is a map, and it might help you a little bit with thinking about, okay, what do I want to keep in mind when I'm doing trauma-informed care with my clients, and how do I apply trauma-specific treatments based on where somebody is? So remember that the very first stop on the train here, the very first step, is always going to be the relationship. The relationship is what's going to carry the day. And you don't want to be jumping into treating before you've got the relationship established. So we want this bond to be there. We want the person to feel a sense of trust and connection with you, that you are someone who's, even if they don't really know you, but there's enough to get started. Remember, it just needs to be good enough. It doesn't have to be perfect. And sometimes that's just saying, I don't even know, I can't even imagine what you've been through. It sounds, just overwhelming and terrible. And I want you to know that I'm here for you, and I'm going to do my best. You're setting it up, the healing relationship. You need to come back to this over and over again. It's not a one and done scenario. It's always there to be cultivated and reinforced. And you might have breaches in it where you need to come back and say, I didn't get that right here. Let me try again. I'm so sorry. I misspoke. Really learning how to work with ruptures in the therapeutic bond and repair them. We talked about our 4S's: safety, stability, structure, support. These 4S's are so key. This is really the infrastructure for them to do the trauma work here. So it's going to be hard to do this if we don't have this. And it's hard to do this if we don't have that. So creating a safe internal, external environment for therapy to occur. This is going to be things like coping skills. What happens when you start to get into the hot zone? We talk about those hot symptoms. Will you be able to recognize it? Or do I have to recognize it? Are you going to be able to recognize the cold symptoms? Are you going to be able to stay in that window of tolerance so you're not up here, down here? Usually in this stage, you're doing a lot of the regulation. You're the one who's going to say, you'll ask a question, you'll see them start to turn red, their hands are sweating, they'll be kind of breathing fast, and you might be the one to say, all right, wow, okay, so I asked you a question about what what's it's like to be alone at home, when everybody's out of the house. And I'm seeing you have a lot of reactions to that. Let's just take a minute and resource. Let's get you back into the workable zone. And let's use a technique. We'll use, a square breathing. Let's breathe in, let's hold, let's breathe out. Let's do a little mindfulness moment or something. You're helping them regulate. You're teaching them skills. And one of my favorite tools, obviously, is DBT. These are a lot of the skills people need to learn how to be mindful of their own state and start to learn how to tolerate distressing emotions, distressing impulses, so that they can actually work with them. If they can't tolerate it, they're going to try to get away from them. And they'll usually do that through behavioral strategies that are feel good now and pay later. So we want to teach them how to pay attention, how to stay with difficult emotions and sensations so they can work with those emotions and sensations and then behave in the world in more effective ways in their relationships with their peers, their coworkers, their families, the police, whoever they're interacting with. So this is a really important skill training, teaching people how to manage themselves as a result of the trauma. And by manage themselves, I don't mean they're doing it on their own. You're usually helping them quite a bit while they're internalizing those skills. And you're also then helping them when they get here. Now they can remember, naming here is the key. So what's shareable is bearable. If they can't talk about it and they can't stay in that workable zone, then trauma is reignited. You end up with not resolution, but trauma reenactment. And we don't want that. A common mistake for people doing trauma work is to have people jump in at stage 3. Oh, tell me about what happened to you. And they haven't worked on the infrastructure first. So this is really important. Another common problem is we want to get people reconnected to their community. We want them to, feel a sense of belonging and jump back into like a support group or a community organization kind of structure, get them into the workforce, those kind of things. And that's might be too much too soon. So we want to get them there. But this last stage here is really about building bridges and finding commonalities with other people. But they need to also recognize their own individual story first and be believed and heard and help make sense of all that before they can oftentimes jump into this. Again, if we put people here too early, a lot of times they feel like they're damaged or like other people have some kind of a secret and that they don't have it, and they feel like they're like a foreigner or an alien, or if people really knew what happened to me, they wouldn't like me. So we want to be careful about managing all of that. So your style here is you want to be able to be clear about supporting people as they're moving through these phases that we just looked at here. You want to have access to 3 styles when you're doing trauma work and trauma-informed work. And the 3 styles are mostly a guiding style where you kind of know the map and you're helping people navigate it. but you're also following their lead. If they're needing support to be slowed down, you're paying attention and you're going back to maybe the symptoms or the safety and the structure. But you're also saying, and we want to have some direction. We want to know where we're going with this. I'm not just following you wherever you're going. I'm not just telling you where we need to go, but I'm really listening mostly and tracking and working collaboratively so that we're not re-traumatizing people. We're giving them agency and choice, and we're directing them toward their goal. And their goal usually is some version of having their life back. Maybe it's different, but a life that's worth living, a life that's not a life where they're living in fear or that they're shut down or not able to participate in important, meaningful activities. So when we're saying directing, we're not saying you are telling them what to do, but we're pointing them in the direction of their values and meaning and helping them discern how their choices and their actions are either taking them closer to that or taking them away from that. And that, I mentioned earlier, is we want to help them really get this trauma-informed lens. So we're working on all the stages, not just jumping in at stage 3 or 4. It's too much too soon, typically, for people, and they tend to not do well with that. I want to end our time together here. Just got about 20 minutes left here, just highlighting the importance of self-care. And, burnout is not self-care. We hear about burnout as being overwhelmed and frustrated, even exhausted, but it's not the same thing as secondary trauma. So when we talk about burnout, we've got lots of things you're supposed to be doing and you feel like you should be doing, and there's just not enough time or energy or resources. And I could definitely see how what you're up against right now, with this influx of 3 million refugees, that's a lot of people, schools at over 30% capacity. We saw in a news report earlier today that schools have 30% more students than they did just a month ago. So people are going to be burned out. They're going to be tired. They're going to be emotionally exhausted. But we're adding to that exposure to trauma. So this is what we call compassion fatigue. We've got burnout plus exposure to trauma or secondary trauma. And that is what Charles Figley calls a natural consequence of stress resulting from caring for and about people who are traumatized. And he actually includes animals in there too. And that's normal. We want to really emphasize that that's normal. And it's the cost of caring. But we want to also not just stop there. We want to ask ourselves, how do we reduce burnout, if possible, by getting resourced, finding external resources? How do we metabolize secondary vicarious trauma, our own projections about what should be or shouldn't be, and avoiding becoming co-victimized from exposure to that? And we've talked about PTSD a little bit. We've looked at the hot symptoms and the cold symptoms of PTSD. Remember, we can be diagnosed with PTSD as providers, as frontline workers, just by hearing stories and being witness to this. So it's a real thing. It's not something to be minimized. Compassion fatigue usually takes 2 forms. And the first one that most people get into is getting over involved. They can't put it away and they're taking it home, and they're doing so much that it starts to intrude in their own personal life and affect their own personal relationships. And they might even say things like, I have to do this. I'm the one who needs to do this, instead of or agencies doing this. And I'm part of that. But when other people are also part of that too. And it's not just about me and my efforts. The underinvolved typically happens as a reaction to the first one, which not always, but usually that's how it works. And that where someone just says, I can't help these people. And we start to see them as objects rather than subjects. And that is also distressing. So we don't want that. We want to learn how to be helpful without jumping into being either a fixer and a rescuer on one hand too much, or a persecutor and not doing enough on the other hand. So looking at our own histories of trauma growing up, our current exposure trauma at work, asking ourselves, are we letting everything in or everything out? Are we keeping everything in or keeping everything out? Are we becoming overly attached to the outcome? It's, I'm the one to do this. No one else is doing it. Or becoming too detached. It's your problem and I can't do anything. So good luck with that. These are risk factors for compassion fatigue. Being stoic, I can't say that I have emotions. I can't say that this is hurting me. I can't ask for help. Seeing ourselves as a giver, I only give, I can't receive. I can't receive support from other people and just lack skill. So you're here learning skills, you're here learning about this. Sometimes people just have never heard of it before. We are at risk as helpers for compassion fatigue and burnout, and it can really affect our own lives and our own relationships to very detrimental outcomes. People can feel severely depressed, even suicidal, when they are exposed to this degree and constancy of trauma. So it's not just a recommendation, but really a vital necessity that we have a place to process our own feelings and concerns about providing trauma-informed care. So it's normal. It's not about when it happens or if it happens. It's really about when it happens. And we need to be clarifying our own boundaries, letting good things in and keeping bad things out. Again, I mentioned earlier that sometimes when terrible things are happening to people we care about, it's hard for us to appreciate our blessings or our things to be grateful for because we feel guilty about it. And I want to highlight that is something that you do want to be appreciative of. You can still be grateful and have an attitude of gratitude for what you have, while you're also simultaneously recognizing that other people's situation is very different. We don't want to be beating ourselves up with feeling guilty. It's not going to help. Committing to self-care, not just self-indulgence. Those two things are quite different. Self-care is long-term, and self-indulgence is usually a short-term kind of, I want to feel better now because I'm overwhelmed. And sometimes they look the same thing. Eating ice cream could be an indulgence, but it could also be a self-care element too. It just depends on how and how much and why. We want to be compassionate without being apathetic or sympathetic or empathetic. And I don't know how that's going to translate, but let me see if I can give you kind of a working definition. Compassionate means I'm feeling with you, but it's not happening to me. So I'm seeing it through your eyes. And empathetic means, at least in this version, is that I'm experiencing it with you. So I'm not just seeing it through your eyes but I'm also seeing it through my eyes if it's happening through me simultaneously or to my kids. And that creates a scenario where you might have a harder time staying in your socially engaged nervous system because now you're feeling like you're under threat and you might not have the kind of resource state that you need to be effective. Letting go of the outcome, meaning that we can experience pain, we can hold pain, we can bear witness to pain, but we also are accepting that it's happening. And we say it's not happening or it shouldn't be happening or this isn't fair. All those things might be true, but they can prevent us from being effective. So we want to accept the reality of what's going on and prevent pain from turning into suffering. You might have seen Stephen Cartman's drama triangle, where this trauma can get reenacted. A lot of times the client shows up as the victim and we try to fix the situation. And sometimes that can turn into a dynamic where we need them to appreciate us in a particular way or respond in a particular way. And if they don't, then we can feel like, well, I'm doing all this for you, but you're not responding. So we can flip over to the persecutor. And then the client oftentimes will try to rescue us so that we can, again, go back to being a rescuer and not feel like this. And this dynamic is pretty common when we don't have the supervision and support to talk about it. But what we want to do is flip that around. Instead of having a rescuer and a persecutor and a victim, maybe approaching it more as, how do we create, instead of being stuck in the victim, how do we create a new meaning or new reality, even though all this other stuff happened? A lot of times the victim is, because this happened, I'm destroyed, I can't do anything. I need everything to be a particular way to get started. And the rescuer might be trying to give it to them in a particular way, but they can't. So everybody's kind of stuck. The flip here for the victim is to become a creator and to be thinking, even though I don't have everything I need, what can I do to get started? It doesn't have to all be here or be perfect. I can get started. The rescuer can turn into a coach, and instead of doing it for somebody, help them explore their own resources and do it with them, not for them. And that persecutor, instead of being cruel about self-care and boundaries, can actually be a challenger and ask pointed questions that help somebody, look at themselves, but don't create more trauma or difficulty. And we see this in particular when we looked at our two strategies before, where we're directing and guiding, right? Directing and guiding. So we need a little bit of both when we're approaching our work with trauma-informed care. So we're working on resilience, helping people bounce back. And that means that we're really developing a sense of resourcefulness and resourcing, those inner resources, those external resources, and our own internal resources and our own external resources. So we can feel good about the work we're doing. That's compassion, satisfaction, and not feel daunted by it. That's going to be compassion fatigue. Okay, so to kind of wrap up today, the trauma-informed components, we've got those 4 R's that we mentioned before. That means that trauma-informed, you realize the widespread impact of trauma, you recognize the signs and symptoms, and you respond by fully integrating this into your policies, procedures, and practices so that you are not re-traumatizing people, you're helping them with resolution. So those 4 R's, very important. Been talking about that. Our trauma-informed approach can be implemented in any type of service setting or organization or private practice, and is going to be different or distinct from trauma-specific interventions. We need those too, but this is the two go together. And this is designed to specifically address the consequences of trauma and to facilitate healing. When we're going about this, trauma-informed approach to client care, again, is trauma-informed care seeks to change the perspective. What's going on with you? What's wrong with you? To what happened and why does your symptom presentation make sense? And the 6 principles in trauma-informed care is safety and trust. We've talked about that a little bit already. Helping people feel relatively safe, or at least safe enough to get started. It doesn't have to be perfect, but we want to, have people feel like they can at least get started with that. They trust you, they trust the environment, there's transparency, they know what the expectations are, they know who you are, what your approach is, maybe even about the map. Sometimes I even share with people the stages of trauma recovery. Like, this is really what we're going to be doing. They've got support from peers. You've got support from peers. You both have support. You're not doing this alone. Really need to not be practicing in isolation. Trauma isolates. Trauma likes to keep people separated and isolated. And relationships, especially well done, heal. And people tend to isolate because of trauma. They don't want to be seen as weak or needy or whatever. And so they end up not getting support. So we need to be careful about that too. We need to collaborate and work together in a sense of mutuality, not one person helping another, but we're 2 people who are experiencing this life together. You're in your role and I'm in my role. So there's that, but we're not doing something to another person. We are helping them with their own, moving in a direction of a meaningful life and their own values, empowering people, finding their voice, giving them choice, and taking into account that the one thing that they might be presenting with, the trauma that just happened, is also embedded in culture and history and gender and other things as well that might be bigger and even more rooted. So not just single issues. Now, the last stuff here is more about organizational stuff. So I'm just including it so you see it, but it's beyond the scope of what we're going to do today. So thinking, how would you approach safety, trustworthy, and transparent from an organizational perspective? And there's some questions here that an organization would be asking, maybe in a leadership fashion or a leadership meeting or executive meeting. A team might be asking these things. So we've got the keys there, mutual support, collaboration, mutuality. We just went through all of those. And I'm happy to provide these slides if anybody wants them. They're in English, but if anybody wants to come back to that, you're sure welcome to do it. You can also go to this website here and find out much more about this. In the United States, SAMHSA stands for the Substance Abuse Mental Health Services Administration. So finally wrapping things up here, trauma-informed approach to client care. You're looking at your policies, how your organization, your team is set up. What is the physical environment? Is it supporting safety? Is it allowing people to get started and come back? Remember, there's kind of two parts to therapy. People need to get there. And once they get there, you want them to stay there because they can't benefit from treatment if they don't get there or stay there. And a lot of what we're doing in those early moments from screening and intake and all those parts of getting people started is helping them feel like they belong and they can benefit from treatment. So engaging all the way, keeping them from feeling like they're just a person receiving services. Involving other people, cross-sector collaboration, screening and assessment and treatment that's trauma sensitive and isn't just getting information from people and having them feel like they were interrogated. That doesn't really get people to come back. Training and workforce development. So remember I said the trauma specific or trauma sensitive environment is training non-clinical staff on how to not be a therapist, but how to respond to people who might be escalated and to help them come down so they can stay in treatment and not be dismissed early. Monitoring and quality assurance, making sure that people are benefiting from treatment and that there's money and ways to evaluate progress. These are all key parts of trauma-informed care on kind of a macro level beyond the individual treatment you would be providing. And again, I gave you more specifics on all of those that you're welcome to learn more about if you want to take this at a higher level in terms of agencies. So I think that's basically what we wanted to focus on for today. And I want to just got a few minutes left, so I'm going to stop sharing and invite folks who maybe had questions to look at that. And I'm seeing a few comments, very structured, informative. Will it be possible to get a presentation or a video of this? Like I said, I'm happy to share, a PDF of this if anybody wants that. I'm not sure if you have access to the chat box, but I just put a copy in the chat box, a PDF. So if anybody wants to disseminate that via email or whatever, you're sure welcome to do that. Other comments or questions you want me to speak to right now? Okay. We've got some evaluations in the chat box to encourage people to give us some feedback about our presentation. And I want to just really end with appreciating all of you for being here and taking the time to learn this and think about these concepts. and apply them to yourself, your teams, to the clients you're working with. It is hard work. It's heart work. And I appreciate you being here and stepping up and facing this challenge, even though it's very painful and difficult. How to work with children 4 to 5 years who have been, I think you mean raped by Russian soldiers. Is that, Andriana, is a huge question for a 1-minute response. With sexual, yeah, that is probably bigger than scope. I feel like if I were to answer that now, it'd just be a brief nod. But sexual abuse, and especially a sexual assault, the thing I know about kids, being very brief and short here, is play therapy. If you know anybody who does play therapy, to have kids have a way to work through what happened to them using figurines, sandboxes, sand trays. Kids are super resilient, and I'm not predicting that this is going to happen, but what often does happen with kids is they can work out what happened to them and what they needed through the supportive experience of a play therapist or guided play structures. And through that play, actually access more resources and support, and they can integrate what they needed but couldn't get. And oftentimes with surprisingly very few symptoms at the end of it, because that trauma doesn't turn into complex trauma 30 years later. Remember, and this sometimes is shocking, and I don't want to shock anybody. Remember that it's not about what happened to you. Remember our 3 E's. So that's an event, but the experience of the event and the effects of the event are the other 2 parts of that. And one thing we can do with kids is we can help them find ways to process the effects and the experience of it, so that it doesn't have to turn into a lifelong devastating trauma. But that obviously takes some focused attention. I mean, the key thing with sexual assault is to let people know they didn't deserve it, and to believe that it happened, and help them create safety. Oh, we've got the Ukrainian colors. Thank you. Tetrana. Thanks a lot. Yes, thank you. You're welcome. Anything else we want to ask or say before we're a couple minutes over so far? I'm happy to stay as long as you need. Well, it looks like we might have wrapped up then. So I will once again just appreciate our wonderful team at the Academia, who have supported this process, to our wonderful team of interpreters and translators who have been live casting both Polish and Ukrainian translations of all this. You do have a copy of the PDF, and I'm thinking that this was recorded and that people will have access to it later on once it's all been processed and made available. So with that, I will thank you again for being here and wish you well as you apply these concepts in your work.
Ryan, marvelous. Such a hard topic, really very, very difficult area. And yet, I don't know, you are a talented lecturer. I must say, everything seems to be so clear and so helpful. We have to have you back again in Poland. So just wait for our email inviting you again. You really know how to do it, and that's very helpful at the stage for us and for our colleagues from Ukraine. We can see their response. So thank you so much. Thank you
welcome.
very much. And we'll keep in touch.
Okay, thank you.
Thank you.
Bye-bye.